Welcome to Journeying Through the Eyes, the EMDR podcast that's here for EMDR clinicians and all therapists to be able to help support you in your journey. Today, we are talking about ketamine-assisted therapy, and I am out here in Twin Falls, Idaho. I'm Kathy, the owner of Rewired 360, which is your EMDR hub and your university, and then I also provide couples in EMDR therapy at Willow Creek Counseling. I offer certification and consultation programs for EMDR therapists, and I met Shelle Welty, our first guest, that way, and we're so excited to have her here. Shelle, of course, can probably introduce herself better than I can, but she's out there in California and has done a ketamine-assisted psychotherapy training and has a lot of knowledge on that, and we partnered that with a new clinic here in Twin Falls with Dr. Michelle Harcourt here, who is with Rock Behavioral Health. And so she's on the medication provider side, and then she's also providing TMS. So I thought just get all of us together, and I am just excited to begin working with Michelle and getting patients to her clinic. One of the struggles here was that there was not providers in our area that were utilizing protocols or procedures with patients, and so we'll kind of talk about some of those ethical dilemmas and challenges. So I'm going to kind of turn it over to Shelle to introduce yourself and maybe expand kind of on what I've already said.
Yeah, sure. I'm a licensed psychologist and I practice remotely right now. I'm licensed in California, Utah, and Michigan. So I've had some in-person work in both Utah and California. And I say that because that's part of what got me interested in psychedelic work was some work I was doing a few years ago as a program director at a outpatient trauma group practice in Salt Lake City. And there were just clients coming in who had gone for IV treatments, weren't coordinating that with any sort of therapy. And of course, I was always interested in how could we offer more helpful ways of working with trauma. And so I decided to do Integrative Psychiatry Institute's 10-month program, which was ketamine, psilocybin, and MDMA. And ketamine is the only one I can use in any of the states that I'm working in right now. So that's kind of just a little bit of what got me interested in it.
Do you know if any other states approve psilocybin or MDMA in the United States? Are there other states that?
Oregon, Colorado, and New Mexico have legalized psilocybin, though I think New Mexico, they're in the process of that. It's not started yet. I think there might be one other state, but I'm not sure.
Good to know. I'm looking at getting licensed in Oregon. So just for one patient who's moving. And so that could be good information there. So wonderful. I'm going to turn it over to Michelle. I'm going to put you on mute and turn it over to Michelle. All right, go ahead. Can you unmute? Hold on. Ask to unmute. Go ahead. There you are.
Unmuted?
Nope, you're ready.
Okay. Like Kathy was saying, my name is Michelle Harcourt. I'm a doctorate prepared nurse practitioner specializing in psychiatry with 6 years of inpatient experience. I worked at an acute psychiatric facility. And my interest in ketamine basically first grew out of one, frustration that there wasn't more options for patients, and two, hope that we can, with ketamine, that we can truly, promote that true psychological healing with neuroplasticity. And I think it's a great option for patients. It's a safe option when it's done correctly. And it really drew my attention. I trained in Utah at a clinic that is very successful doing ketamine and TMS. I had a few sessions there training. And I was, I don't think skeptical is the right word, but years ago, I just wasn't sure how I felt about it. And after doing my own research and training, and a big driver was this of seeing patient outcomes, seeing the true healing that comes and the relief with the depression and the improvement just really drove me to build something that, is medically approved and safe, and then really work with therapists and psychologists in getting the psychotherapy portion of it for CAT.
Yes, and that's pretty much my experience with why I wanted to use ketamine. I was not use, understand ketamine and be able to really figure out what the clinics in our area were about and how was it treated, and then more treatment and training. And so kind of more with Shelle's help, kind of asking some questions and being getting some more understanding, I became more aware of the positive treatment outcomes. And then I had a patient who's now successfully completed a round and is off for antidepressants. And so she was a chronic, she experienced some therapy abuse from a therapist. And so she had a lot of chronic trauma. And so we were able to get her to a place where now she may be not needing the antidepressants anymore. So that's a huge success story. And so I was really grateful for that outcome. And so I want to kind of start. Would each of you mind sharing kind of your story about how you became involved? We've heard a little bit of your background, but how did you become involved with ketamine assisted psychotherapy, and what was the shift for you that made you sort of invest in this as a protocol and treatment option?
Is that for me?
For anyone. So yeah, we'll just be organic here.
Okay. Kathy, could you repeat the question? I'm sorry. Are you there?
What made you interested in ketamine assisted psychotherapy? And sort of what kind of, what's your why, I guess, in regards to what was the hook with making you see this as a viable treatment option? Shelle, do you want to go maybe?
Jump in. I think, along with Michelle referred to this earlier, but just the outcomes, the research, especially for treatment-resistant depression, is really strong.
Mm-hmm.
And that's so difficult for clients who just keep trying things that don't work, which creates more depression, when nothing works. And just the possibility of opening that up for other things as well became really, ketamine is interesting because there's not a strong push for research as much because it's already FDA approved. So I think that's growing now that it's becoming so widely used. There's more and more research, but I think it's just like learning any other modality of working with people. It feels like here's something else that might help. That other things weren't working for a client, so this might be an avenue to pursue. It's just different, and one thing as part of just educating clients about ketamine is even if it doesn't go exactly as you expect, it's helping your brain. It is what we do know is it is helping to grow new nerve cells, and that's helpful in lots of ways. So I think just the low risk of ketamine, the short duration of it as a psychedelic-like substance, and just something different. It's just very different. Although, as a lover of EMDR, as I went through the training, I just kept feeling like it's so similar to EMDR in the way that we work with it, and it's very inner-directed, brings together a lot of different things that people have been thinking about. So I think just having an avenue that's different and another potential tool is always really attractive to me.
Absolutely.
Yeah, I think I'm really what you're talking about in regards to the short duration. I was looking at some of the clinics where I'm at, and we were getting feedback of like, oh, there's no protocol, we just take it. Or I had a patient that was recommending some things with psilocybin. Okay, so what's the protocol? Just take it and trip at home. I'm like, we can't do that. That's not a protocol.
Yeah.
No.
So those were some of the challenges in our area, and I needed to have a provider that was working with the therapist and kind of being able to help us understand it and work with sort of that opportunity to be able to work with that neuroplasticity. And one of the things I'm fascinated with is the brain regrowth and the regeneration. I think I could actually see it on the brain scan. And so as I began to research it and look at that regrowth, it's actually one of the articles Shelle shared with me. I was like, wow, that is amazing. So I definitely kind of echo that. Michelle, I'm just going to turn to you for a moment.
Okay.
As a medical provider, what kind of interested in it, and sort of how was that path for you?
So in, becoming interested in it, it was very, very important to me that I was fully educated, that I understood the indications, I understood the risks, the side effects, and the benefit. So, just really making sure that I understood first off, the evaluation and diagnosis portion. What patients are appropriate for ketamine, what patients aren't. You know, the patients that any hypertension, is there active substance abuse, any psychosis, ketamine is just not appropriate for them. But just doing a full evaluation, making sure that there's a full evaluation on medications they've taken in the past, medications they're currently taking, and then understanding more of what really constitutes as treatment resistant depression. Looking at the protocols for outside of even insurance coverage, but have they failed other forms of treatment, like the two separate medications from two different classes, a failure in psychotherapy, failure in other options.
Yeah. So when you're thinking about, and Shelle, you can kind of pop in here too, what does collaboration with therapists on your side, or Shelle with medical providers, look like? I know, Michelle, maybe just having a new practice, you might not have had a lot with that, but I know that you know what you're looking for. So what does that look like as far as collaboration?
I'm happy to jump in because I've done some work to develop those relationships. After I finished my program, I did want to have good, who do I want to refer my clients to? And in LA, there are lots of possibilities, but I wanted to feel like I understood who, what their philosophy was, what their training was. And so what I have done, because again, in California, there are so many possible, prescribers, I found some medical providers through my program's alumni um, forum. So psychiatrists and nurse practitioners who had gone through IPI's program. And also I'm part of another group association called Anana Rising, which is a space for different therapists and prescribers to collaborate in different ways. So I found a few through there in the different states that I'm licensed in. And I just asked them, I reached out and said, I'd like to talk with you about maybe partnering, with clients. And so I had a chance. I'm just so grateful to all of them because they're just so collaborative, and I think that's part of the training for all of us is you can't do this by yourself. So I cannot do this by myself. I cannot prescribe ketamine. I have to stay in my lane. I don't decide what the dose is, the frequency, any of that. That's not my place. And they're just so gracious. They met with me and we talked through their training and how they like to work with clients, how to contact them. I have a prescriber in California who has monthly consultation groups that are open to any of the therapists who work with her. Really anybody, but mostly just the therapists who have clients shared with her, which is a chance to hear her input on our cases and also learn how are other people working with ketamine. And also just very accessible. We'll say, I'll be checking in with your client the day after your session, and I'd like to check in with you and hear how that went, because they want to know, is that the right dose? Do we need to make some changes to the frequency? And just really want to hear any feedback I have, because I know the client often a little better than they do. I've maybe met with them for some time at that point. So I just feel like, unlike most of my work, CAP work is just incredibly, wonderfully collaborative and so rewarding because I learn from the medical provider and we just work very closely together. So I really love that part of the work.
That's really
Shelley, I couldn't agree. I'm shaking my head, everything you're saying. I couldn't agree more with you. Eventually my goal would be to, even with a patient, sit down with the therapist, sit down with me and the patient, and kind of talk about what's going to be happening, what to expect, how we're going to be collaborating with each other, what medical documentation is the therapist would be helpful for the therapist to have. Make sure that there's appropriate release of informations for collaboration, but really, really be part of a team with that, where the therapist and I are talking very, very closely. And I would like to develop, I'm working on it, with a referral process, but also just a quick sheet that I could fax over to the therapist. Today's date, the dose of ketamine, what was their intention, how did they respond, just to really keep that collaboration open.
Yeah, and these opportunities, right, as a therapist, I've seen patients the day of and the day after. That was just something her and I came up with, and knowing that that's recommended is great. And so I've just kind of been out here, rogue, kind of working with these patients and figuring out, consulting with other clinicians doing it. So I think, we would like to have some more supports out here where I'm at, sort of as a therapist side in Idaho. It sounds wonderful what you have over there, or wherever, all the states, Shelley, that you're at, and working with this, because I think it's an opportunity to, as an EMDR therapist, I was kind of explaining to Michelle about the neuroplasticity. So if you're an EMDR therapist, what happens is you come in, we gain history, if you're a regular therapist, and then we do regular therapists if you're treating patients, and then we stabilize them. And then when we're reprocessing a target, a lot of my work has been around sort of enhancing the experience of what they had and gathering information from what occurred during the session and new insights and processing that, sometimes with bilateral, and mostly just trying to figure out how that relates back to their treatment and what are the new insights. And so that's kind of been really good for me. When you think about sort of, Shelley, let's talk about, we're working with a therapist and we've seen a patient for a long period of time. So we're going to go therapist to ketamine referral. What kind of criteria do you use to determine whether a patient is a good candidate? We've talked about, failed a couple of different trials of medicine. I can share my experience, but I'd like to hear yours.
Yes, I think the key right there is I know the client well. So you're saying I've already seen them for some time. Even if someone contacted me about, I'd like to try CAP, I would not just take them and say, okay, we'll get started. I'll give you a referral. I would want some time to get to know the client for a few reasons. One, I need to know their history. As Michelle was saying, there are some contraindications for this type of therapy. Do they have some bipolar symptoms? Is there any history of mania or psychosis? And sometimes some other, highly dysregulated clients just might not be, I would want to know them well before we would make that decision. And also, we know that the experience itself is so impacted by the mindset of the client and the setting and the relationship that they have with the people around them. And so I would want us to have had lots of time to talk about any concerns they have, to make sure they fully understand that they aren't afraid. We're not rushing. And so it would be someone who maybe I've worked with them for some time and they're continuing to feel depressed. Maybe they've made some progress, but it's, not where we would want it to be. And I don't have any reason to think that they would, have any of those contraindications. We have a strong relationship. I'm aware of the stressors in their life. Is this a time it's good? Or is there a lot of chaos in their life? And this would not be a good time to do that because you need space for that. Or sometimes also, aside from depression, specifically, like there's just a rigidity, which might be related to anxiety or OCD or, any number. I hate to even try to diagnose specifically so many things, but just like we can't quite crack it. There's just a stuck way of thinking that the neuroplasticity of ketamine might help to open up a little bit, or even some trauma processing where it might open up you with just a little tiny dose, just a little more space to work with.
Oh, that's a great way of saying that. Yeah, that's exactly, you just put into words my felt sense of that. With this one patient, I was like, you're motivated, you're highly resourced, you've had all of this depression, and she would just come in very low. And had another patient had a negative outcome with the provider, but she also was like, lots of trauma, and I'm trying all the tricks, EMDR and inpatient psych and all of these things. And it's like, you know what, this might be a good option for you. And so I think that little crack is a really important comment. Michelle, what are your thoughts in regards to this?
So I wish I could get one of those vinyl signs above like the door that said "Don't waste neuroplasticity," because it's just so important that they do follow up with the psychotherapy portion of ketamine. It's so valuable to have that option, to have that openness, to have that growth, and making sure that it's not wasted on patients. I mean, still, as we've talked about, ketamine is going to be beneficial, but to really get the full grasp of it and really benefit from it long term, we need that psychotherapy portion. I also really think that the intention setting for each session is beautiful, and it's something that I would like to share with the therapist, to say this was their intention for today's session. They didn't feel like they were able to achieve it. They did feel like they were able to achieve it. This was a beautiful response. So really, just like we've said, continuing that collaboration with therapists, that this is what their intention for this session was, and then they're going to come see you and process how it went, and things like that. But just really keeping the collaboration and utilizing every benefit that ketamine has to offer.
So my question here is, what if they're in the clinic and receiving the treatment? This is more of a Shelle question, and they have more of a adverse, or what's the potential of them having a negative experience with ketamine? Is that typically the course or the questions that you talk about, and what happens if there's an adverse thing? I know Michelle's really good at her clinic at monitoring blood pressure and having people available. How do you process if something is less than ideal with the patient as the therapist?
Well, are you, because I guess there are two scenarios. One is they go to a clinic and have an IV or IM experience and then follow up with me for integration, or they do a sublingual lozenge with me as a therapy. So in that one where they're actually doing the whole process with me, the adverse effect, I think I'm not afraid that something terrible is going to happen. So I would have talked with the client, and the medical provider would have talked with them about any potential difficulties and challenges. And we would be at peace with that before we started. How do you ground yourself? Like if I'm working solely with the client, I take the blood pressure, the pulse. I know what the medical provider has given as limits on that and any concerns they have about that. I'm not worried that a client's going to have like an adverse medical reaction. And if they do, I have somebody I can call. Immediately I have a prescriber who is available to me, but I don't really have that fear. Ketamine doesn't have that sort of, risk, I guess, in it. And so I want to really convey that to the client, that there may be some heightened anxiety. You may notice some difficult things come up. We can talk through, I'll remind you. So did I answer the question?
Yeah, I'm trying to get into, if you're basically, I think of it as a bad trip, right? Is a possibility of them having negative experience when they're in this state likely, or is it more, I think?
Yeah. And that would be the preparation for, we don't know. We'll set an intention. It's sort of like EMDR. We have a direction and it will go where it needs to go. And it could be kind of scary. It could bring up things that are very difficult. It's okay. We have a plan for that. It also could do nothing, which is also pretty disappointing. And I want them to be prepared for what does that, how do we work that into your treatment? That it didn't turn out like we thought it would. And that sometimes is really difficult to work with.
I kind of bouncing off of that, I think that as we're starting ketamine, I explain to the patient that disassociation does not have to happen, and it's not necessarily even the goal with treatment. If you do and it's a pleasant experience, great. I also tell the patients, if at any point you feel like you're getting scared, or you feel like you're out of control, or you feel like you're heading to a spot that you're not comfortable with, just let me know. I go in, we have protocols for, if they need medication, if they're anxious, and to help kind of ground them again. But setting the expectations for the treatment that you may not get euphoria, you may not disassociate. That's not the goal of it, though. If you do, again, that's an added benefit, but really being upfront and clear about what the expectations for the treatment are, so that there's not this intense disappointment if it wasn't everything that they had thought, knowing what the realistic expectations of our treatment are.
I think that's really important because I've actually heard from a couple of providers like dissociation is the goal. And one of my questions was, that's what we're trying to work with is how do we, as therapists, we're trying to work with disassociation and those kinds of things. And so I thought, but what's the point of putting them into that state? As a therapist, we're trying to redirect and help them cope. And so to hear you say that is like, oh, okay. Thank you. That's one of the reasons like we're on board and we're looking forward to working there. I want to kind of ask, from each of your perspectives, as we begin developing these relationships with the provider, the therapist to provider, the provider to the therapist, what kind of questions can therapists, we'll start with you, Shelle, therapists ask or look for in a provider that might be a good quality person to work with, and then Michelle will go back to what kind of therapist are you looking for to work with?
I think it's important to me to know where they were trained, if our trainings have taught us similar things so that I feel like we're on the same page. So I might ask what training they've done and just what their general approach is to the process. Some prescribers like to do the sessions themselves, and then I do the follow-up work. And so if that's what I want to do, that's fine. If I'm going to refer them in hopes that they'll prescribe sublingual so that I can work with the client, then I would need to find prescribers who do that. So I need to know my preferred mode of administration and make sure that fits. And I think just hearing when I have talked with prescribers, I have worked with really great ones. They're just excited about the collaboration. They're excited about this new tool that we have and the outcomes that they're seeing and the possibilities, and they want us to be in a collaborative relationship. And I think, as we're talking, I'm just thinking, yeah, those are the people I prescribe or I refer to because I know how that's going to go. And some of them are a little less that way, and I just tend not to refer as much to them because I don't know exactly how that's going to go. So just shared excitement, I think, about the possibilities for clients.
Absolutely.
Yeah, my experience too was like, when I began working with these clinics, one clinic was like, well, just put them in a room, check their blood pressure, and yeah, that's a treatment. I'm like, okay, so that's where I started, and I'm like, okay. And so I was coming from an addiction realm of like ketamine, and then Matthew Perry came up, and we're like thinking about like, what's the dosing? When I hear it, I have no scalable understanding of like, oh, ketamine's very low dose. What he was doing was very off the books, and so there's some stigma and awareness around that, right? And then other providers were like, I'm asking them, what's the protocol? We just do it. I'm like, okay, so like what happens if they need help when they're at the clinic? Oh, they can ask the receptionist. And I just at that level, I'm like, okay, this has to be a little bit more like monitored, or there was this being a new provider, I'm trying to understand like what is the best practice here. And so I was doing my own research and trying to help this patient get the best care possible, right? And so I'm kind of like, let's collaborate. And there's like, yeah, they got the dose. I'm like, do you want to know what we did or something like that? And it was just like, oh, there's just nothing. And so I'm like, okay. And so those were some different experiences. And then I also had a patient who didn't review the medication list. The provider didn't review the medication list correctly and ended up having serotonin syndrome. And so I knew a little bit about like the risks, and there were some underlying factors with that. But I was also like, I feel as a provider, like going back to Shelle, like I have to know them. They have to trust what I'm recommending. I have to give them the outline. And so I've done some trainings, with EMDR and ketamine assisted psychotherapy. I'm looking more at kind of some of the other trainings out there, but I want to be able to say like, here's the gold standard, or at least a standard, so that you know which clinics you can work with and have good supports. So that being said, Michelle, what comments do you have there, or what are you looking for in ketamine assisted psychotherapy?
The training education that they've had preparing for it, I also think trust 100%. Patients, we care about them. We want them safe. I definitely want to know and trust and respect the person I'm referring them to. I also think that, just being able to be on the same page together as far as the training and education and understanding, the routes of administration, what the potential side effects are, really combining that medical portion so that I'm not a therapist. I don't claim to be a therapist, but being able to at least have someone there to say, with psychotherapy, with ketamine assisted therapy, this is what you can expect, to just trust and continue that collaboration. I think that it's very important to, not that therapists need to be 100%, skilled, informed on the medical portion, but I think it's important that at least a basic understanding of what routes of administration are an option, what are the benefits of different routes, and the length. Some of the routes, the patients in and out quicker. What are the expectations with each route? So just to be able to really educate the patient on both
That's so
ends.
important, and instead of just saying, here it is, here's the treatment, because this is what my clinic offers, knowing like these other different routes and that assessment process is really good. And kind of what Shelle said, I pick providers based on what thing I think is best for the treatment of the patient, right? And so I want to ask kind of how can medical providers and therapists kind of improve collaboration, and any challenges maybe Shelle you've encountered with working with medical providers in that area, and an outcome that was less than hopeful?
Yes, tell me so we can avoid those mistakes.
Practice wisdom, Shelle. Practice wisdom.
Yes.
Well, I guess I don't have any terrible examples because the providers I work with are so take initiative to make sure that we work together well. I do like what you said earlier, Michelle, about having some sort of form for the history, just to sort of summarize for the provider ahead of time. Here are the basics of what I know, and then we can talk further if they want after that first meeting with the client. I do like some sort of check-in after after the first session, just to see, did that seem like the appropriate dose, or are there things I need to keep in mind? I don't have any great ideas because I've had such positive experiences with the providers I've worked with. Yes.
Good. And I think it's as simple as, after their session, shoot over a little note. This is the dose they got. This was their intention. This is how they tolerated it. And this is, what we did today. It's simple. It's very effective. It's very informative, and it continues to build that continuity in care.
Yeah, and that's so important. I know Michelle and I have both worked with like the high acute kind of mental health inpatients. types of people. And so I think, just this, I guess there's a sadness sometimes when you see these repeat people and repeat patients that are chronically mentally ill or have experiences. And if they can have a chance at not having that their lifestyle and have a chance at a different type of therapy, I think I'm on board with that. I think there's a lot of questions that we have to ask ourselves, a lot of ethics and decisions that have to be made. And so I think for therapists and providers, like making sure that you're trained, you know the correct questions to ask, that collaborative relationship is so important, that we're being able to think through the thought questions and things correctly. Did you have something, Michelle?
Yeah, I also think it's valuable for us to help each other out, be another set of eyes, watch for red flags
Yeah.
that this might not be the appropriate treatment for the patient, or that there might be some concern with some addiction, maybe being able to, be a second set of eyes for each other.
So yeah, what if there's a patient who does have an addictive background and they're considering this? What kinds of, this is a question I guess for you both. How do you kind of help the patient with that if you really feel like it's an appropriate referral?
So for me, addiction or substance use can definitely be self-medicating forms for what's really going on, and looking into what's the real diagnosis here, what am I treating, being very, very open, collaborative with risks, and if I see any of these risks, we're going to need to pause our treatment and talk about it. Unfortunately, I've already had that. I've had to address that with a patient here in the clinic, and we decided I recommended this isn't appropriate. I'm getting calls from other pharmacists and there's new controlled substances on board, so this is not appropriate. We do need to stop the ketamine sessions at this time. However, I would still love to work with you, help address other medications, have you continue with therapy. But I am not afraid to stop the therapy if I see red flags and it's just not appropriate.
I don't know that I have much to add to that. It's, I think when I worked with Journey Clinical, they only gave a few doses at a time, like 2 weeks worth at a time, to help kind of get to know the patient before giving more. But yeah, I think that's part of the history, is knowing the potential there, not only for are they going to misuse the ketamine, but are there other addictions happening that are going to interfere with ketamine outcomes? So,
are we triggering more addiction tendencies? Exactly.
Yeah. I think just having that discussion with them, like, this is a risk, we can look at it, looking at how long they're sober and what their use of choice is, and say, but also, look, these are the symptoms. Here, I think this is more of a question for Michelle. I know you're a veteran. Thank you for your service.
Thank you.
Appreciate that. You're, hometown badass,
Thanks.
I want to ask you, sort of with this different veteran population, do you see any more indications with that for veterans or any type of people who have had military experience, any kind of prognosis or things to address there?
I don't want to answer, or I don't want to speak out of turn. I haven't worked with a lot of veterans yet, and I'm definitely hoping to, but I don't want to answer that incorrectly. So I haven't seen a whole lot. The off-label use for ketamine for PTSD is definitely something to consider. But while I'm relatively new in the process, I really am just really trying to make sure that the indications are the FDA approval on label. But I'm interested in looking more into the options with PTSD or trauma, things like that, and the help. I can't answer that quite yet, but I definitely will be able to.
And I wanted to ask you also too about ketamine and TMS. So when you're thinking about a patient, can you just describe the TMS process and how you kind of decide between TMS and ketamine, which might be more appropriate? for
Yeah.
a client?
Absolutely. TMS and ketamine have very similar mechanism of action, and it's to increase that neuroplasticity, restore growth, help train, new thought pathways, open up for learning, growing, building. So right now, the difference in kind of what I'm recommending is access to care, affordability. Some of these, the TMS, if they don't have insurance, it's just so difficult for them. The insurance approval is a big one. And so, kind of piggybacking off of each other, and ketamine and TMS work wonderful as well together, alternating days, but availability, there with TMS, they have to come to the office every day, 4 to 5 days a week for 30 days. And so, if that's not doable for the patient, then okay, well, let's talk more about ketamine.
And what is your protocol for administration of ketamine? I know you do IM and I guess it's sublingual, other one?
So I do either IM or Spravato.
Spravato.
Spravato, if patients have insurance, if they meet the criteria for treatment-resistant depression, I love using Spravato. It's really great when insurance covers it. It's a smooth process with it. Whether it's Spravato or IM, the protocol for the timing is the same. For the first month, we do 2 sessions a week. They can't be back-to-back days. You can space them out to, where Monday, Friday, you just can't do like a Monday, Tuesday. And so that you do for 4 weeks, and then you go down to 1 session a week for 4 weeks. And then from there, that's where I have a talk with the patient, where are we at with maintenance? Would you like to continue, do you want to see how you do without it? But patients even come in once a month for maintenance after we finish the protocol. So also too, with the routes of administration, where I offer the IM and the Spravato, I haven't really been able to pinpoint a whole lot of difference in IM versus IV with the absorption. I'm open to more collaboration with that. My research, I just haven't, but I'd like to talk to people more. Why do you prefer IV over IM? Just not seeing a whole lot of the difference with the results. IM is a little quicker. It's easier. It's less expensive for the patient. So if they don't qualify for Spravato, then IM is a great option for self-pay.
Shelle, I want to ask this question. I know that you had said when I was looking at sort of doing some more training to help, basically help Michelle's clinic, get more trained therapists and provide training in our area about ketamine-assisted psychotherapy. You had said with a lot of these programs, there's an expectation you'll also have an experience yourself with the ketamine. Can you talk about that for us and share with our listening audience about if you're a therapist, those considerations, and if you're looking into a program, understand what that means?
I have gotten on board with that expectation. When I started training, I had no history with psychedelics, just, strangely in my life. That. And so, therapists and prescribers all in our program were saying it's just different. Like I don't feel like I need to have bipolar disorder in order to help someone with bipolar disorder.
Exactly.
But, they were saying, but this is a different state of consciousness. You need to have some familiarity with what happens for people in that state. And so I did. Actually, it was really helpful because my experiential session with ketamine, nothing happened. And I was really angry. I had to go to this experience. I had to pay for a psychiatrist visit. I had to get the medication and spend a weekend there, and nothing happened. And so, in my first psychedelic experience. And so that has actually been pretty formative for me. Sometimes it doesn't go how you think it will.
Mm-hmm.
Then I went, as part of the program, we could do an extra 40 hours of psilocybin training in Oregon. So I did that, and I did have a different experience. And it would be difficult for me to fully relate to people's experience, I think, without having had some, not that every experience is the same, but some feeling of what's happening when the level of trust that you need to have people in the room when I'm just really not I'm capable of getting up and going to the bathroom and all of that, but I'm not in the same state of mind. I need to know that they're not going to tell me something that would throw me off or anything like that.
Mm-hmm.
So I have really, gotten on board with some sort of experiential to at least set the stage for how this might go for your clients. And the fear of what's going to happen. And yes, there's a rush of anxiety at first and how that feels for them. And I think it's helpful to know that.
Does that time frame, and maybe you can answer this or not, does the time frame of the effects of the psilocybin and ketamine, are they longer or are they the same or?
Yeah, like ketamine is what, maybe 45 minutes, maybe an hour, depending on the client. My psilocybin session was 6 to 7 hours. It's a lot, you set aside a long period of
Okay.
time, and a lot happens during that time. So the person sitting is actually helping take notes for, I cannot possibly remember everything that came up during those hours. And if I share it, somebody can take some notes for me, but it's a long time.
So we talk a lot about EMDR, sort of, your ego state, younger self, and your older self. So this question is for you. If you were to look back at your post-psilocybin self and to kind of talk to your pre-psilocybin self, what kind of information or what kind of things could you share there?
I think just be present and be open to what's coming up and go with it. You don't forget, like, you can't remember everything. Mark like 2 or 3 things that especially stood out. Either just mark it in yourself or share it with your sitter, because you can't do it all. So what feels really important, just hold that, because you're not gonna do psilocybin again next week. You're gonna work on that for the integration work. Somebody needs to help you keep coming back to, why did that feel important? What does that bring up for you? Are you making change based on that? So I think to be open to what comes up and to make some choices that I'm going to work with that piece.
Did you feel a different sense of self after the treatment?
I wouldn't go that far that I feel a different sense of self. I still refer, but I've had other psilocybin experiences as part of training since, and so they work with each other. But I trust it, I guess. I trust that what came up is still important. And so I, from each of my experiences, can pick out, here's the image that came up, or here's the awareness that came up, and I need to keep working with that. That was important. Don't forget it, because it's easy to just get, with any treatment, get on with life. But there are specific things that came up for a reason, and I need to keep working with that.
Mm-hmm. I have a question for both of you. Do you have a preference, if you had experience or seen it's beneficial one way or another, for the timing of sessions after the ketamine treatment? I've heard some of my patients say, I'm just kind of groggy the rest of the day. I don't really want to get into it a lot, versus, is it beneficial to have them do ketamine and therapy on the same day?
I wouldn't do it. The only thing I would do that that would be helpful if I'm sitting with them at the end is to just, whatever they're sharing, take some notes, because it's hard to remember. And maybe if there's a real positive feeling or positive resource that came up, to do the installation piece of it, the resourcing piece. I would not do any sort of trauma processing, or they are not in a place to do that. And I don't know that I would do it that week, but in the next session, talking about what seemed most important and maybe doing some resourcing out of that, maybe working toward some processing. What do you think, Kathy?
I think that I've done it depends. So my experience, yes, the day of is just more processing what came up. And so if I wasn't actually a sitter, but if I could say, what are your insights? I would just more gather the insights and the data on the day of and just help support them and help is in the beginning of the treatment of like, let's understand what this is. How are you feeling? I have done it the next day. The next day would be more installing like if in her case a resource came up, and by installing we mean using the eye movements to increase the neuroplasticity and the adaptive information, and continue to create those networks. But I do agree, during this time I have not done any like reprocessing of a specific target or memory. I wait, we gather the treatment, we gather we gather the targets, we create a treatment plan, whatever appears relevant or a resource, and kind of are just doing the history taking and investigating. And I think at the point maybe where they're ready to reprocess and they're still in ketamine, I think we need to have that joint decision together with me and the client of like, how are you feeling? Where are you at? I haven't had one that said, yes, in the middle of ketamine, I'm ready for this deep trauma work. I would definitely wait on that, but it also just depends on the client. I've had clients come in and like, boom, 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 and they're just like, move through it. But then I've had clients that are just slow. And so it just depends on the brain we're working with, I would say. A lot of the assessment and processing and their comfort level with me. And again, I'm only referring people I have a new and established relationship with, and kind of like to the comment earlier, if people call me and say, want ketamine assisted psychotherapy or EMDR, it's like, yep, we need a lot of assessment before we're ready to kind of, and so it's kind of different in Michelle's realm of like her assessing and her appropriateness, may take a little less time than us building rapport, but I think it's the same general idea, that we're able to work with that and build the rapport and have a good understanding, a lot of preparation. But I'm not one that's going to say I want therapy. I want to do ketamine unless they've had a long history. Like a lot of what we call it in our land is different therapists, different modalities, CBT, and things that didn't work before we get into this conversation, or they're really depressed, and want a different outcome, those kinds of things. So any closing comments that you guys would like to share or say we need you to share with patients where they can find you? If they're looking, of course, Shelle's not in Idaho where we are, but she's licensed in those states. Michelle and I are here. I've only done EMDR, ketamine assisted psychotherapy training. So we're trying to get more education and training for providers as far as therapists in our area. But what would you guys like to share before we go about where to find you, and any closing comment?
You can find me online. Just Google my name and there I'll be. I think it's important for therapists and providers in this field to be familiar with ketamine is, I think I said this earlier, had clients just coming in and telling me I went to the IV clinic 2 days ago and, we hadn't coordinated how can we best use that time. Yeah. So you're going to have clients who find out about ketamine and don't even know to coordinate the treatment of that, but you need to be familiar with how that works and maybe be able to take advantage of that neuroplasticity at the time. So I think it's just important to know some of the basics about ketamine work.
I agree. I can be found online, Psychology Today. My office number is online. Just Google me. I also would like patients to know, come in for a free consultation. If you're interested in it, let's talk. Let's see if you meet the criteria for it. Let's see if it would be appropriate. And, if it's not, you're not out anything. But if you're interested in it, you have questions, come on in and let's talk about it.
And Michelle is one of the first providers in our area, is the first provider in our area for TMS. So I think that's a great asset too. Also knowing like if you do have some of those risks and benefits, addiction concerns, whatever, there are other routes that we have available now. So I'm so excited just to kind of begin building this partnership and helping clinicians really understand what this is and how to move forward with it and the opportunities available. So I appreciate you both. We have Shelle Welty and Michelle Harcourt here today with us. I'm Kathy Couch, your EMDR therapist, trainer, and consultant. out here in Twin Falls, Idaho. I hope you have a beautiful weekend, and we will see you next time. Take care.